Hello everyone. Today we will discuss about brain tumors. Since it is a very big topic, I have made it as a part 1 and part 2 session. So starting off with the introduction. Primary brain tumors are the second most common solid tumors in the childhood and the adolescent. So primary CNS tumors. These are the most common solid tumors in the childhood and adolescence. Moving on with its etiology. Etiology of these brain tumors are not well defined. But 5% of the cases account for the familial syndromes. So 5% of cases account for familial syndromes. So the familial syndromes associated with the brain tumors are, so we'll see the familial syndromes that are associated with brain tumors. So these are, first one is neurofibromatosis type 1. Next is neurofibromatosis type 2. Third is von Hippel-Lindau syndrome. Fourth is tuberous sclerosis. Fifth one is Charcot syndrome. Okay. Next point here is, when there is a ionizing radiation exposure to the cranial region, these are associated with increase in the incidence. So there can be increase in the incidence of the brain tumors when there is a cranial exposure to ionizing radiation. Okay. Next we will see the common tumors in the childhood according to the age group. So according to the age group, 0 to 14 years, in children between 0 to 14 years, the most common brain tumor are, first is pilocytic astrocytoma, second one is medulloblastoma, and primitive neuroectodermal tumor. Okay. Next we will see the location of the tumor. So what is the most common location of the tumor? It is mainly according to the age base. So there will be an age related differences in the location of the tumor. Age related differences in the location of the tumor. So when the child is in the infancy stage, it is less than 1 year, the most common location is supratentorial. In the child between 1 to 10 year age group, most common location is infratentorial. And when the child is more than 10 years of age, it is again supratentorial. So it is supratentorial, infratentorial and supratentorial. Less than 1 year, 1 to 10 year and more than 10 years of age. Next we will see about the tumors classification and the how they are being classified. First we are going on with the congenital and neonatal brain tumors. So congenital and neonatal brain tumors are, first one is germ cell tumor, second is choroid plexus tumor, third is embryonal tumors, Among the embryonal tumors, we have this one. It is primitive neuroectodermal tumor. Second is medulloblastoma. Third one is atypical teratoid. Fourth one here is astrocytic tumor. Fifth one is neuronal and mixed neuronal glial tumors. Okay. Next we will see its classification according to its site. So classification of the brain tumors according to the site. First one is posterior fossa tumors. So the posterior fossa tumors are, first is medulloblastoma, second brainstem glioma, third is ependymoma, fourth is atypical teratoid tumors, and fifth one is cerebellar astrocytoma. Okay, these are posterior fossa tumors. Next, second one, we'll go on with midline. So midline tumors are first one chiasmal glioma, second one craniopharyngioma, third one is pineal region tumors. These three are midline tumors. Third is supratentorial tumors. In supratentorial tumors, first one is astrocyte. This is cerebellar astrocytoma. This is just astrocytoma. In astrocytoma, we have 4 gradings. So first one is pilocytic astrocytoma, that is grade 1. Second one is diffuse astrocytoma. Third one is anaplastic. And fourth one is glioblastoma multiforme. So that is glioblastoma. Okay, this is first is astrocytoma. Second is ependymal tumors. In ependymal tumors, we have first one as myxopapillary. Second one is cellular. That is grade 2 is cellular, and grade 3 is anaplastic. So these are supratentorial tumors. Third one is oligodendroglial tumors. Oligodendroglial tumor. Fourth among this group is neuronal and mixed neural glial. Mixed neuronal glial tumors. These are, first one is ganglioma, second is desmoplastic infantile tumor. Okay, so these are the classification of the tumors according to its site. It is posterior fossa, midline tumors, supratentorial tumors. Next is neuronal and mixed neuronal glial tumors. We will see the important tumors alone in detail here. Okay. Next we will go on to the clinical manifestation of the brain tumors, clinical features. So the clinical features, it depends on the tumor location, tumor type and patient's age. So the clinical features depend on tumor location, tumor type and the patient's age. The tumors, that is midline or the infratentorial tumors. So the midline and these infratentorial tumors, they have a classical triad of features, such as, because midline tumors can block the CSF pathway, which leads on to an increase in raised ICP, thereby causing the features of headache, nausea and vomiting with or without papilledema. Okay. So characteristic of this headache is, so what is the characteristic of the headache in a child with the tumor? These are, it will be a new onset headache. This will be accompanied with the neurological finding. So the neurological findings can be cognitive impairment, behavioral changes, there can be seizures in this child. Third is, it can occur on awakening, or it can wake the patient up from the sleep. It can wake the patient from the sleep. These are the characteristics of the headache in a child with a brain tumor. So what are the other features when the child is having a infratentorial tumors? One is headache, vomiting, nausea. Second, the child can have disorders of equilibrium and gait. Third, the child can have blurring of vision, diplopia and nystagmus. The child can have disorders of equilibrium, gait and the blurring of vision, diplopia and nystagmus, along with headache, vomiting, nausea with or without papilledema features. In child with tumors that are present in the brainstem. Brainstem tumors. Child can present with gaze palsy, multiple cranial nerve palsy, third, upper motor neuron defects. Okay. When the child has supratentorial tumors. When the child present with supratentorial tumors, the child can have focal motor weakness. Second, focal sensory changes, language deficits or disorders. Fourth, the child will present with focal seizures. So when the child has the supratentorial tumor, early feature can be premature hand preference. Okay, this can be one of the sign when the child is having a supratentorial tumor. When the child present with tumor in the pineal region, the child will present with paranoid syndrome. The features here can be, the child will have paresis of upward gaze, second, the child can have Argyll-Robertson pupil, that is accommodation reflex will be present, light reflex will be absent, this Argyll-Robertson pupil. Then the child can have nystagmus on convergence. Fourth, the child will have eyelid retraction. These are the clinical features depending upon the location of the tumors. Okay. Next we'll go to the each tumor in detail. I'll tell you only the main points that you have to write in your examination. Okay. Astrocytoma. So for each of the tumor we will be seeing its classification according to WHO. In that classification you will be seeing its classical site, that is location of the tumor, histopathological features, its genetic significance and MRI features. So astrocytoma, so this is the most common in the childhood. So 40% of the brain tumors are astrocytoma in childhood. First, grade 1. According to WHO classification, grade 1 is pilocytic astrocytoma. This is a low grade tumor or a low grade astrocytoma. This is the most common one. Next, its location, its classical site of location is in the cerebellum and in optic pathway. Okay, they can occur anywhere, but most common site is cerebellum and optic pathway. This histopathological feature. On histopathological examination, you can see Rosenthal fibers. So what are these Rosenthal fibers? These are condensed mass of glial filaments. These are condensed mass of glial filaments. Okay, and they will be having a low mitotic potential. Next, its genetic significance. The child will have an activation of MAPK pathway. It will have activation of MAPK pathway in the form of BRAF mutation. Okay. What are its MRI findings? Its MRI findings can be, there will be a contrast enhancing nodule. So there will be a contrast enhancing nodule within the cyst. So these are the features of pilocytic astrocytoma. This is grade 1. Next is grade 2. It is diffuse astrocytoma. In diffuse astrocytoma, why the name it's diffuse? Because it has a diffuse infiltration of tumor cells. So it will have diffuse infiltration of the tumor cells between the normal neuronal tissue. Okay. Microscopically, that is its histopathological feature. There will be a greater cellularity compared to pilocytic astrocytoma with few mitotic figures and nuclear pleomorphism. This is its histopathological feature. Its most common location is, or classical site is, supratentorial region. Its genetic significance is, there will be mutation in the tumor suppressor gene, that is mutation of P53. Okay. And its MRI feature is, while pilocytic astrocytoma will be contrast enhancing, while diffuse astrocytoma is non-contrast enhancing. So this is about the diffuse astrocytoma. So the treatment of these two gradings, it is grade 1 and grade 2. So treatment of grade 1 and grade 2 astrocytoma is multimodal approach. So one is surgery. Surgery is the primary treatment option. Next is radiation therapy. Third one is chemotherapy. In chemotherapy, what are the drugs they are using in grade 1 and grade 2 tumors? In chemotherapy, these are carboplatin, vincristine, vinblastine, lomustine and procarbazine. So these are the chemotherapeutic drugs used in the treatment of this low grade astrocytomas. Next we will go on to this malignant astrocytomas. So the malignant astrocytomas are grade 3 is anaplastic astrocytoma, grade 4 is glioblastic astrocytoma. So the histopathological feature here is, since it is a malignant form, there will be an increase in the cellularity with nuclear atypia and mitosis. Cellularity, nuclear atypia and mitosis. Plus in glioblastic astrocytoma, the child will present with foci of tumor necrosis. Okay. So the treatment for this is, anyway this is also multimodal approach. There will be surgical resection followed by involved field radiation therapy plus chemotherapy. So there will be a surgical resection with involved field radiation therapy with chemotherapy. Okay, so this is about the astrocytoma. First one grade is pilocytic astrocytoma, second one is diffuse astrocytoma, third one is anaplastic astrocytoma, and fourth is glioblastic astrocytoma. Next we will go on to the second tumor, that is ependymal tumors. In ependymal tumors, first grade 1, according to WHO classification, grade 1 tumor is myxopapillary ependymoma. It is myxopapillary ependymoma. Okay, so the location of this tumor is phylum terminale and conus medullaris. Okay, next grade 2 tumor is cellular ependymoma. So this, since as the name suggests, is ependymal, these are derived from the ependymal lining of the ventricles. So grade 2 is cellular ependymoma. Its location is, most common location or classical site will be in the posterior fossa. Okay, its clinical presentation will depend upon its location, and it will be mostly insidious in onset. It will be a non-invasive one, but it can extend to the ventricular system. So it can extend to the ventricular system. Since it arises from the ependymal lining of the ventricles, it enters into the extends to the ventricular system, thereby leading to obstructive hydrocephalus. So there will be an obstructive hydrocephalus. Okay. Its MRI finding can be well circumscribed tumor. It will be a well circumscribed tumor with gadolinium enhancement. Okay. His histopathological finding will be perivascular pseudorosets, and ependymal rosette. Okay, this is about the grade 2, that is cellular ependymoma. Grade 3 is anaplastic ependymoma. Here, as told earlier, there will be a high mitotic index with microvascular proliferation. Okay, so the treatment of this ependymoma will be surgery. This is the primary modality along with its radiation. So what will be its prognosis? There are two major prognostic factors. So what are the two major prognostic factors? First one is its age. When a child is in the young age, there will be a poor outcome. Second, tumor location. So when the location is in the posterior fossa, there will be a poor prognosis. When the location is in posterior fossa, it will be a poor prognosis. So the two prognostic factors are, one is age, another one is location of the tumor. So posterior fossa tumor will have a poor outcome or poor prognosis. This is about the ependymoma. Next we will see the choroid plexus tumor. Choroid plexus tumor is one of the congenital tumor and neonatal congenital and neonatal brain tumors. Next is choroid plexus tumor. This is one of the congenital and neonatal brain tumors. It is most, since it is congenital and neonatal, it is most common in children within less than 1 year of age. Location. As the name suggests, it is a choroid plexus tumors. It is a intraventricular epithelial neoplasm arising from the choroid plexus. Okay, but predominantly it will be present in the supratentorial region. In supratentorial, it will be mostly in the lateral ventricle. Clinical features, there will be signs and symptoms of raised ICP. There will be signs and symptoms of raised ICP will be present. Okay. Next we will see its grading. Grade 1 is choroid plexus papilloma. Grade 2 is atypical choroid plexus papilloma. Grade 3 will be choroid plexus carcinoma. I am not going into the detail of grade 1, grade 2 and grade 3. In grade 1, this is the